it's my pleasure.
So again, and Dr. Mackenzie, are you joined with someone else there with you?
I have 𝘾𝙊𝙉𝙍𝙍𝙍, who I think you know as the advanced nurse practitioner who works with me.
Hi, Mr. Hayter. How are you?
I'm doing very good. And thank you so much for also joining. Appreciate it.
You're welcome.
Right. So, so we're ready to get started, and we have, so the format is,
I've lost your voice, Amir.
Yes, can you hear me now?
Yes, now I can hear you.
Yeah, I was hearing an echo because of this recording here. So the format, it will be that we'll go through the questions that were all posted online, and then after that, we'll open it up for Q&A.
Sounds good.
So if you have the list of questions, we're recording, and then we can start with the one that was submitted on November 8th from NB Canada, Heart 9.
Okay, I've got the list right here, and so that is the 924 question?
That is it says my daughter's 8 months.
Well, here I've got 5 pages of questions.
Okay, let's start from November 8th.
November 8th. I have it right here. My daughter is 8 months old. Correct?
There you
go. All right. Shall I repeat the question?
That would be great.
Okay, good. So my daughter is 8 months old and has achondroplasia. Is there any testing she should have done? My doctors don't know much. She had an x-ray at 1 month and a test where they looked to see if there was fluid in her head when she was like 2. I'm assuming when she was 2 months or something. Mm-hmm. So we have a child who is 8 months old with achondroplasia. Well, the recommendations that were put forward through the American Academy of Pediatrics by Judy Hall and a group a number of years ago was that all children with achondroplasia should have imaging of their foramen magnum and should be considered for sleep studies to assess for apnea that may be centrally related, which is due to compression of the brainstem, or peripheral, which is obstructional due to a small throat area being made even smaller by large tonsils and adenoids. And also to have hearing testing because of the problems with the eustachian tubes and chronic fluid buildup and middle ear infections. So there are 8-month-old children with achondroplasia that develop normally, and there are ones that are very delayed. So in our practice, if we have an 8-month-old child that is developing normally, and when I say normal, they are following the average developmental milestones for achondroplasia, where the motor milestones are a little delayed compared to average stature. And by 8 months, they're sitting, they may be doing some crawling. Some really advanced kids may be pulling up a little bit. We would not be concerned about compression at the base of the skull. But if the child is delayed, poor head control, not starting to sit independently, and very floppy, we would be concerned about the possibility of compression at the base of the skull, and that child would need imaging and the imaging we would do would be an MRI. Sleep studies we do very commonly. They're easy to do. They require an overnight stay, usually in a pediatric hospital, and they're very, very effective at ruling out the difference between central and obstructive apnea. Does that answer the question, do you think, Amir?
Yes, that sounds great. Thank you so much. And I think it's the question right after that is essentially the repeat of the same question, I believe.
So can I'll make one other comment there, because it's sort of like we just did a huge long thing on achondroplasia. The other thing that young parents with achondroplasia need to know is that in addition to the compression at the base of the skull, the children can have interference in the way that the fluid that bathes the brain is distributed. And as that builds up, it can cause something called hydrocephalus. And the way to monitor for that is to monitor the growth of the circumference of the skull. And we have charts that you can plot your child's head circumference on. And it doesn't matter that it's big. It matters that it stays on the same percentile over time. So if your child has a big head and it's growing within the same percentile for the achondroplasia head circumference chart, that's fine. But if it's jumping up, that would be bad, and that child would need to be evaluated for hydrocephalus. All right?
Excellent. Sounds great. Thank you so much.
Okay.
We'll go to the next question. I think we can jump to the one on November 24th.
November 24th. Okay. My 6-month-old child was diagnosed with type 2 collagen chondroplasia, exact type unknown. So that's very common. The type 2 collagenopathies encompass the spondyloepiphyseal, some of the spondylometaphyseal dysplasias, Nice syndrome, and Stickler. And it says, how important is it for us to get an exact diagnosis? We've had a very tough time trying to find anyone in the medical profession who's experienced with this condition. I feel he should see a skeletal dysplasia expert. He's doing well, but he has breathing issues, cleft palate, and feeding issues. When it comes to anything like feeding, physio, OT, seating, anesthetic, no one knows, and I have to refer to the internet. Should we take him to the UK? And it says kindly, it's either, I think in Ireland they pronounce it Cara. This child lives in Ireland. There are good physicians in Ireland. They tend to be localized to the larger cities in Dublin and Belfast. For a 6-month-old child with type 2 collagenopathy, there's more issues than the mother. I'm assuming that's the mother. Children with type 2 collagenopathies can have problems with the eyes, specifically the vitreous, the retina is not well supported in type 2 collagenopathies, and retinal detachment occurs commonly. These children need to be evaluated sometimes every 3 to 6 months, and it's very important to track this because of the visual problems that can be the result of a retinal detachment. Cleft palate can have issues related to breathing, speech development, and feeding, and generally requires surgical management. Any child with a type 2 collagenopathy can have an unstable upper cervical spine and other spinal deformities. None of these children should be put to sleep without having at least some understanding of what how stable the upper cervical spine is. And that can be sometimes as simple as a plain x-ray with the neck maximally flexed or maximally extended, or it may involve the use of an MRI. And I'm not sure that going to the UK will have, there are skeletal dysplasia centers in the world. The group in Great Britain at Great Ormond Street would be a good resource. Obviously, there's a few centers in the United States that could help as well.
All right.
6 months.
6 months.
From Ireland?
Yeah.
That's easy.
Yep. Shall we move to the next one?
Sure. My daughter with achondroplasia is 11. Is it possible to enroll her in a growth study drug trial at this point? Thank you. Well, the only drug trial I know about is the BMN 111 study. At the moment, she is too old for that trial. I believe the ages right now are 4 to 9. And the stage of the trial that it's at this time is evaluating growth in achondroplasia and evaluating the safety of the drug in the pediatric population. They have evaluated the safety in an adult population already. So there is no opportunity for an 11-year-old to be enrolled in any drug trial at this time. Probably the drug trial will not start for at least several years. Amer, would you like to add to that?
No, I think the age is the main factor, which you already mentioned. I think if there's anything for parents, they would be maybe interested in understanding when can we expect the general availability, number one, and number two, if magically this became available tomorrow, would the children of similar age, like 11 or 12, benefit or not at all?
I think they're still growing and they may well benefit. We don't know yet.
Excellent. So I guess we go to the next one.
Okay, next one is from Lansing, Michigan. And I know why they're asking this question, because they're hosting the World Dwarf Games. So the first thing is, what's the largest operation in the United States? Lansing, Michigan. You get it? No? Oh, okay. So with the 2013 World Dwarf Games coming to the U.S. August 3rd to 10th, what are the benefits of sports for dwarf athletes in terms of flexibility, stamina, core strength versus the potential risks of skeletal and neurological damage? So, for reference, 75 to 80% of the participating athletes have achondroplasia as a primary diagnosis. I would guess that's an accurate estimate. I think that the benefits are all of those things: flexibility, stamina, core strength, the opportunity to participate in sports events against individuals with your same diagnosis and size, the opportunity to meet athletes from all over the world and discuss issues related to your form of dysplasia in other countries. I think there are huge benefits from these dwarf games. I think the potential downside are minor. All these kids will have to have, the kids that have unstable necks will have to have specialized x-rays. People with older individuals will have to have a cardiac and pulmonary evaluation. I think there's really very little downside here. Okay?
All right, thank you.
So, the next question is from Carruthers, California, and relates to a family asking where should their son's spinal fusion be done. So, I don't know that I should be advocating certain centers over another, but I'll give you the background. So this is a 21-month-old boy with brachytelephalangic chondrodysplasia punctata with instability in the upper cervical spine. He has no signs of spinal cord compression. He has a tracheostomy. He gets his medical care at a large center in the West Coast, and the family's happy with this group. He has been, the surgeons have suggested that he would need fusion from the skull to the bottom of the cervical spine. And the suggestion to the family was that the surgeons are waiting till the child gets big enough and his bones are strong enough to support using a halo. The orthopedic surgeon would like to wait until the tracheostomy has been discontinued. So, I'm going to address the issues and not the place. This is a very rare form of chondrodysplasia punctata. It can be associated with cervical stenosis, that is a narrow spinal canal, or instability. You do the operation when the child's spinal cord is threatened or already compromised. You do not wait until the child gets bigger, because during that time, there may be irreversible spinal cord problems. There are sometimes challenges for the surgeon, but we do not wait until they get older or they get stronger. We do it when it needs to be done. And we have to adapt. You do not have to wait until the tracheostomy is removed, unless perhaps there is need for an anterior approach, but even so, you can still do that with a reasonable incidence of infection. So when you choose the hospital, you have to choose a facility where a surgeon is comfortable and experienced at doing these procedures, and that anesthesia is comfortable giving an anesthetic and maintaining the airway, and that the post-operative physicians, usually the intensive care physicians, are comfortable dealing with the issues that occur in these children. That child was 21 months. Is there any other thoughts about that question, or would you like to continue on?
No, thank you so much. I think we can continue on. Thank you.
Okay, the next question is, what are your thoughts on using exercisers, i.e. exercise saucers? My daughter will be 1 year old next month, and I see some people use them with their children. That daughter has achondroplasia. How do I know if the kyphosis is bad? I read that 10% will require surgery or a back brace. None of my doctors know what I should watch for. Well, Generally, exercisers with wheels should not be used. I don't think they're very safe. If you have a wheeled exerciser and you happen to leave the door to the basement open, that could be a fatal injury. I don't mind exercisers that are stable on the ground. There is any sort of system where the child is supported is not a problem when used in moderation. If you use an exerciser to park your child with achondroplasia in for 3 hours, that's not a good idea. If you use an exerciser for a half an hour of playtime, that's perfectly fine. Most children with achondroplasia have a kyphosis. They should not be propped into a sitting position for hours at a time, but short periods is okay. A small percentage of kids with kyphosis do not improve spontaneously when they start walking or when they get strength through their trunk. The next question is from Pakistan. This is a individual with achondroplasia who says they are a student and occasionally has tiredness in their hand when they're writing for long periods. So, achondroplasia not only has problems with narrowing at the base of the skull, but also narrowing of the spinal canal all the way from the top to the bottom of the spine. I've had to treat teenagers with compression of the spinal cord in the part in the neck, so in the cervical spine. That can get so bad that you need to do decompression surgery for this narrow canal, but usually not in someone who is in their teenage or young adult years. You have to make sure that the discomfort is not due to elbow problems or forearm problems, and that the many people with achondroplasia have very, very short fingers, and it can be tough to hold pens or pencils, making it more difficult to write. You can use modifications to pens, such as big grips, to make that better. So first of all, you have to decide what the problem is, and then decide how to manage it. The next question is about limb lengthening for height in pseudoachondroplasia. So, there is extensive experience throughout the world of doing extended limb lengthening in achondroplasia. Achondroplasia is due to an FGFR3 mutation, which interferes with the longitudinal growth of bones through cartilage. The joints are not affected primarily, so the surface of the joints, the articular cartilage in the joints, is normal in achondroplasia. In pseudoachondroplasia, it's caused by a cartilage oligomeric matrix protein abnormality. This results in abnormal cartilage in the joint. So while people with pseudoachondroplasia wear out their joints and need joint replacements as adults, this is very rarely required in achondroplasia. So when you do extended limb lengthening, you put extensive pressure across the joints. And I am concerned about degenerative changes that may occur in the joints of people with pseudoachondroplasia who have had extended limb lengthening. I have used external fixators to straighten out the legs of children with pseudoachondroplasia, but I have not done extensive lengthening because of the concerns that I have and just voiced. I'm going to jump the next question because it doesn't make sense. It talks about sitting but doesn't give a diagnosis. The next question is an individual with achondroplasia who is 40 years old. This individual has extreme back pain on a daily basis, and an MRI a number of years ago showed spinal stenosis in the lower part of the back. The family doctor has this person on painkillers, but that isn't working. And this individual has significant pain throughout much of her body. This individual wore a back brace and leg braces for many years to control leg and back deformity. So, this person could have several problems. So, they are 40 years old and they have back pain and MRI findings of spinal stenosis. Spinal stenosis is present in every single person with achondroplasia. So having an MRI that shows spinal stenosis is not surprising, but it can give you a sense of the severity. Spinal stenosis can cause leg pain and back pain, but it will cause both. And the main thing it does to the legs is something called neurogenic claudication, which means that as you walk, you get pain, weakness, numbness, or abnormal sensation in your legs that improves when you stop and take a rest. There is no mention of that in this question. When someone has severe back pain with no leg pain or neurogenic claudication, then it's unlikely that spine surgery will help unless there is another problem, like a disc abnormality where you have a failed disc in the lumbar or thoracic spine. So this patient requires a very extensive evaluation to make sure exactly where the pain is coming from and then make a decision about how to manage it. One of the problems when the pain is being treated with narcotics for many years is that people can become very dependent on the narcotics and develop psychological syndromes due to chronic pain. And that can sometimes be very difficult to differentiate from the organic problems that are present that cause back pain. Colleen, any comments about that?
Sometimes I think the children and parents need to really think about the symptoms they're having and how often they're happening.
I think that's a good point. For teenagers or young adults who have occasional back discomfort and symptoms of neurogenic claudication due to spinal stenosis do not necessarily need an operation. Sometimes some core strengthening programs, flexibility programs, and weight loss will make a huge difference. So surgery should not be the first resort. It should be after all other avenues have been explored. The next question is related to the first question we dealt with, which is questions about what kind of studies a young child should have. And we talked about the use of spine imaging and sleep studies earlier in the program. Part of this question was, when should she see an ear, nose, and throat specialist? She's had a runny nose for 6 months and 3 ear infections. And I would say, of course, that this child should have already seen an ENT specialist at this point. Recurrent ear infections and a runny nose in a child with achondroplasia should be managed by an ENT surgeon and probably will require myringotomy and tube insertion. The other part of this question is that the mother is worried that the lower spine sticks out quite far. I think what she's saying there is that this child has quite a sway back. This is very, very common in achondroplasia and is completely normal most of the time. Occasionally it's not, but 90-odd% of the time it's just part of normal development. The children start with a round back deformity and then evolve over the first couple of years to a sway back deformity. The next question is a young lady with a COLA2A1 exon 19 mutation. Evidently, this young lady has contacted my office, and the worry is that she is 2 years old and has an unstable neck. So the question here is related to one that we have already addressed. The mother asked, I'm sure it is on a case-by-case basis, but it just seems to me that it is so dangerous to not be done sooner rather than later. I keep getting told the same thing over and over, that she is too small, come back in 6 months. There has been no MRI done on her neck, only x-rays. And from the mother's understanding, sometimes the bones are not well ossified and it is difficult to see what is going on in the neck. And I couldn't agree more. These young children with type 2 collagen problems, probably spondyloepiphyseal dysplasia, can have unossified necks and significant instability that is hard to evaluate with plain x-rays. They need flexion extension MRIs, and these can be done safely. We just published a paper about this. The surgery needs to be done when the spinal cord is compromised or being damaged. You do not wait till the child gets older to do it. And I think we've already made that point. The next question is from a young married couple. The mother has achondroplasia and the father has osteogenesis imperfecta. And they were wondering what the chances are for their children to be average height, achon, and osteogenesis imperfecta. A very interesting and very common genetic question. So achondroplasia is caused by an autosomal dominant mutation. And what that means is that when one parent, and we're going to deal with these both separately, okay? So when one parent has achondroplasia and the other parent doesn't, then the opportunity is for one half of the children to have achondroplasia and one half to be average stature. In osteogenesis imperfecta, by far the majority of the causes are autosomal dominant. So it's exactly the same thing. If you have one parent that doesn't and one parent that does, then half the children will have osteogenesis imperfecta and half won't. So what is an interesting problem is which children will have achondroplasia and osteogenesis imperfecta. And you know what? I'm going to refer that to a geneticist, but I think it's 1/4. But I could be wrong. The next question is, are there any differences, subtle or significant, in the medical prognoses of hypochondroplasia with the common mutation, those versus those without this known mutation? You know, I don't think I can answer this question accurately. We know that there are several mutations that are associated with hypochondroplasia that are different from the mutations that cause achondroplasia. Achondroplasia mutations tend to be what we call transmembrane. Hypos and thanatophorics tend to be either intra or extracellular mutations. And I do not know if there have been relationships of the phenotypes of those different mutations. And what that means is does the specific mutation change the way that the expression is seen in people? So if you take people with hypochondroplasia with 3 different mutations, how do they vary? And I don't know that I can answer that question accurately. So the next question is about the BMN 111 study. It is asked, how many inches do you anticipate that the drug will do to the height of a person with achondroplasia? The answer to that question is absolutely unknown. Currently, we know that in a study that we're doing in our institution, that the level of that denatriuretic peptide that the BMN 111 is higher in people with achondroplasia. What we don't know is what will happen when you give even more of it. We have no idea whether it'll affect height, whether it will affect bone growth yet. We cannot answer that question. The next question is related. Is it possible that this drug will decrease the occurrence of other complications frequently associated with achondroplasia, i.e. spinal cord compression, kyphosis, and bowing the legs? It is possible that if this drug stimulates growth, that the incidence of spinal stenosis, the narrowing of the spinal canal, will be less. It certainly is possible. We just don't know yet. I do not understand the next question. It comes from England. It says, this woman's daughter, age 7, has had her head expanded due to too much pressure, and she had a shunt put in, which is working fine. It says we have just been back in a hospital again for headaches, and they say she needs another head expansion. So I am guessing that this is not achondroplasia and that this is probably a form of craniosynostosis. And what that means is that our skull consists of a group of bony plates that have growth centers between them. And when some of these growth centers fuse, it prevents expansion of the head and causes problems with hydrocephalus, or can. I think what they're asking is that my daughter already had some surgery to separate the plates, and it seems to be reconnecting again, and how common is it to have to go back in again? And I can't answer that question. That would be a question for a neurosurgeon. So that deals with all of our questions that I can answer.
Dr. Mackenzie, there's one more question that came in online like an hour before the call, which I believe you don't have from on the printout. So I'll read it out, and this is from Ohio. So I wanted to know if my child with achondroplasia, 1-year-old, this child is getting visible veins on the eyelids and on the under eye and forehead. Is this a sign of something? Also, should this patient doesn't have full control yet, or the child doesn't have full head control yet, and is that an indication of something? Again, the child's 1 year old.
Okay, so this is a really common issue. So when you have someone with achondroplasia who is 1 year old and doesn't have good head control, that's important. That's very delayed motor development. When you see veins in the over the skull and the forehead, that can mean that the venous drainage from inside the skull is not normal. And the reason that those veins develop is the blood tries to get out of the head any way it can. And when it can't drain through the normal big veins that drain the area around the brain, it drains out through every crack and cranny that it can. And that can be related to several issues. It can be related to hydrocephalus. It can be related to foramen magnum stenosis, or it can be related to narrowing or obstruction of the venous outflow from the skull. We know that the jugular foramen, the jugular vein is one of the main veins, can be very, very narrowed in the achon skull. And sometimes this can get clotted off. So it sounds like this child needs to be assessed. And I would think MRI would be appropriate.
Great. Well, those are all the questions, Dr. Mackenzie, and thank you so much for your time here and expertise. We really appreciate it. And so I was going to open up the lines here for any follow-up questions. I have a couple minutes here if that works for you.
Sure.
So let's see here. Hi, so now we're available for questions. So folks who are on the phone, you can mute or unmute yourself to ask a question. So if you have a question, feel free to unmute yourself by dialing *6, and you can ask your question. And no questions, it sounds like. And then also, folks on Skype, if you had a question, you can unmute yourself and also ask a question. But And we'll give it just another minute here. All right, well, it sounds like no follow-up questions. Again, Dr. Mackenzie and Colleen, thank you so much for the time and the expertise. We'll have these Q&A recorded and put up on the web for people to search for in the future.
Sure.
You're welcome.
Great. Nice talking to you.
All right, thank you again. All right, then. Okay, everybody on the call, thank you so much for joining.
Bye, everyone.
I was going to, Dr. Mackenzie, let me just change one mode here on the phone to make sure I didn't do something wrong.
Okay, sure.
Hi, is there any questions from the phone? Okay, great. I just wanted to make sure that. All right, well, thank you again, Dr. Mackenzie and Colleen.
You're welcome.
Bye-bye.
Bye-bye. Bye.